All right, ATI Chapter 48, Viral Infections, HIV, and AIDS. And when we go through this and we look at how these are separated, we have antivirals as one little group here by itself, acyclovir against cyclovir. And those are going to treat some more common, a few different common viruses that we'll look at, and we'll go over those. And then the rest of these, all of these other drugs, are really going to be based on the replication, how HIV replicates. We talked about that in patho. We're going to talk about it again, and we're going to stop along the way, and we're going to try to identify the drugs that are used to treat that, or at least the types, and then we'll go over them. So if we look at what a virus is, it's a non-living agent that infects bacteria. Yes, viruses can infect bacteria. In fact, they're trying to develop antibiotics that use viruses to kill bacteria. They can infect plants, they can infect animals, and us, including us. So they're intracellulars, they're intracellular parasites. They can infect specific hosts, specific types of cells, which is what we see at HIV, because they need certain molecules to get into it. So they can often be really, really specific about what they're infecting. So they must be in the host to replicate. They can't replicate on their own. They don't really survive very well outside the host. They don't even make all of enough of the DNA to cause replication. So they're surrounded by something called a capsid, which is a protein coat. They contain a few dozen genes. These are really simple. They either have RNA or they may have DNA. And that just contains information, more information needed so they can replicate. So that's all they are. So they're just this little protein coat with RNA, enough RNA in them to keep them dividing. It's just that when they're successful in a cell that we need, that's when they cause diseases. So they may have a lipid envelope with protein spikes that trigger the immune response. And I have here hemagglutinin and neuraminidase. That's when we talk about like H1N1 or something like that. Maybe you've heard H1N1. That's the identification of the virus. It's saying which type of hemagglutinin, H, and which kind of neuraminidase, N. So this can change in different flus. These molecules that are sticking out of there can change, and that's why we keep having to take different flu vaccines, because they can mutate, they can change, they can, travel, whatever. HIV is a little bit different. It has a different set of proteins. It looks a little bit different, and so that's kind of one of the things that makes it a little bit harder to kill. But viruses in general are harder to kill. So we can't even cure the common cold. So that's another problem. So therapy for viral infections, mature particles are called virions. That's what the viruses are called when they're ready to infect. Most viruses are self-limiting, so usually we just fight them off on our own. They require no pharmacotherapy. Rhinovirus that causes the common cold, we don't really treat it. Maybe people will take vitamin C and they just keep trying different things until they get over it on their own. Some viruses cause serious diseases, though, and require aggressive therapy, and we do have some therapies. HIV is one of them. Herpes virus, there are treatments like acyclovir for herpes viruses. But herpes virus can cause significant pain and disability if left untreated, even like meningitis. Hepatitis is another virus, or can be viral. Influenza, and we've all heard of influenza, the flu. So viruses mutate rapidly and drugs can become ineffective. It's difficult for the drug to find the virus without injuring normal cells. Remember, these viruses live inside the cells. They have to live inside the cells, but they also have to travel to infect other cells, and that's where HIV treatments come in. So antiviral drugs tend to be specific to one particular virus. So these drugs are not like bacteria. They're not broad spectrum. They tend to be pretty selective. So let's look at a couple of just antivirals before we get into HIV. So the prototype is acyclovir and ganciclovir. Acyclovir can be oral or topical, and we're talking about like HSV1, so herpes simplex virus. I think it's the one that's on your mouth. Again, cyclovir oral and IV. Okay, so mechanism blocks viral DNA replication. So it blocks this molecule called DNA polymerase that's needed for the virus to divide, and it blocks specifically the viral DNA polymerase. So thereby prevents the reproduction of viral DNA, and then your immune system might be able to come in and knock it out, or at least control it. So primary therapeutic uses, acyclovir is for herpes simplex and varicella zoster viruses associated with like chickenpox, things like that. Again, cyclovir, cytomegalovirus, there are a lot of diseases caused by cytomegalovirus. Prevention therapy for clients who have HIV and AIDS, so it can be used as a prevention along with the other drugs of what we're going to see is called HAART therapy, H-A-A-R-T. So again, cyclovir can also be used organ transplants to prevent viral infections and other immunocompromised states. So if someone is immunocompromised, then you can use it as a sort of a prophylactic treatment or preventative. So adverse effects, acyclovir, phlebitis, inflammation at the site of infusion, mild discomfort associated with oral therapy, so maybe see some nausea, headache, diarrhea, gingival hyperplasia, okay, so around the gums. Again, cyclovir, suppressed bone marrow, that's a little more significant. Leukocytes and thrombocytes are especially affected. Fever, headache, nausea, diarrhea. Okay, so let's talk about HIV. And I have two slides that are almost exactly the same. We're going to try to go through this in a semi-organized way. But remember, HIV targets CD4 cells. Okay, so that means helper T cells. So helper T cells are the CD4 cells. So the problem with HIV is that it's actually attacking immune cells, and immune cells are supposed to fight against viruses, but here the virus is attacking specifically CD4 cells. Helper T cells are the ones that are primarily affected, but you know, the truth is that something like a macrophage also has CD4, but it always settles in the helper T cells. HIV does. And so that's what we're most concerned about, and that's what we want to count to see if those levels get too low. So they use a process called reverse transcriptase. So they start out with RNA as part of the virus. So the virus itself has RNA in it. And so what it does is it reverse transcribes, it makes a DNA of itself, and then it inserts itself into the host DNA. So to get to that, and so we call that reverse transcription, because usually transcription is when that's what we learned, right? You take DNA and you transcribe it into RNA. Okay, reverse transcription is going the other way. We're saying, oh, we have RNA, we'll just turn it into DNA, and then we'll integrate that into the genome. So let's go through the process again, just like we did in patho. Entry or fusion. So the virus has to fuse with the cell. So if you have the virus, and you can see it down here, there's the virus. It wants to infect the inside of the cell, of the CD4 cell. So it has to fuse with it. It has to have something that identifies it, and that's going to be the CD4 receptor ultimately. But in order to do that, there has to be this molecule, this protein, a co-receptor on the side. You can barely see it here, and it's called CCR5. That's one of them. It's called CCR5. Without CCR5, the HIV can't bind. And there are people with mutations in that CCR5 that can't get HIV. So it needs that little receptor to make it in. So there's also something on the virus itself called GP41 that also has to be there. All of that stuff has to be together just for entry, for fusion of the virus and entry into the cell. Okay, then once it's in there, remember that RNA has to reverse transcribe. It has to turn into DNA. Okay, and so that's called reverse transcription. It turns into DNA, and then that DNA has to become, because it can't just run itself. It doesn't have the means to do that. It can't just do it all on its own. So it has to become part of the host DNA in this case. And so we call that integration. We say that it integrates, after it's reverse transcribed, it integrates into the host DNA, and then it becomes part of that gene or that DNA. So the integration of viral DNA into the host DNA, and then you just turn it on, and then you just activate it, and then it just starts running. And as it runs, it starts to make these long chains of proteins that are going to be viral proteins. So So that's what happens, right? You have DNA, you read it, and then you make proteins from it. So it does, but in this case it starts making viral proteins. Well, it makes them in long chains that have to be cut. So if you can imagine the long chain, and let's say there are a whole bunch of different proteins. So it has to cut them. And it cuts them with an enzyme called a protease. Okay, so it cuts this long protein into smaller proteins. And then you have a bunch of viral proteins, and then those can assemble into the virus and then go out to cause more disease. Okay, so all we have to do is interrupt those steps, and that's what something called heart therapy does. I know, it's a fun name. It has nothing to do with the heart, not cardiovascular, but it's HAART, highly active antiretroviral therapy, heart therapy. Okay, so it's a multi-drug treatment plan. We kind of introduced that in the last section. So it's a multi-drug plan, multi-drug therapy, prevents possible resistance that may occur with the use of only one drug. And it just makes it more effective because you're hitting it at a lot of different places. So the first category that we're going to go through are fusion and entry inhibitors. So they block the fusion of the virus onto the T4 lymphocyte by blocking this molecule called GP41. And I have this different picture up here because it labels GP41. Okay, it's a name there, and it sits right here. It's part of the virus. When a drug, we give a GP41 inhibitor, blocks it, then it disables that virus. It makes that virus less able to fuse. Okay, so we call that a fusion inhibitor. And also, then the virus has to bind to this CCR5 that we mentioned last time, this little co-receptor, okay, which is here. So it has to bind to the CD4 receptor, but the co-receptor has to be there. It's called CCR5. If we give a drug that blocks that, then we block entry, and then the virus isn't able to get in. Then we can have a couple of different ways. So now reverse transcription has to happen. So there's nucleoside, should be nucleoside, reverse transcriptase inhibitors, NNRTIs. And what those do is they kind of pretend to be, remember the AGCT, the nucleosides, actually the, yeah, so nucleosides and nucleotides. Well, those have to be integrated, those have to be around to make DNA. And so what you can do is you can block that DNA from even being made. One way to do it is to give a drug that kind of mimics the T, thymidine, oh gosh, I can't put it together right now. But you can give a drug that mimics the T, and then what happens when that tries to be integrated or put into the, or not integrated, but when that tries to be put into the DNA, then it falls apart. It doesn't work because it's not the right thing. Okay, so they resemble natural nucleosides or nucleotides that are the building blocks of DNA. Non-nucleoside reverse transcriptase inhibitors, they just block an enzyme that's needed for that reverse transcriptase. Because remember, we're trying to turn the RNA into DNA, which means we're going to need some of those nucleotides and nucleosides. We're going to need those. And we're also going to need an enzyme to do the work. So we can either block or give a fake nucleoside, or we can block the enzyme. And that's what these two groups do. So then the integrase inhibitors, so once we've made that, it has to integrate into the DNA. So there are integrase inhibitors that blocks the integrase enzyme. It blocks the enzyme that's allowing that DNA to move into the host DNA, the newly formed viral DNA into the host DNA. It prevents that. And then the proteins. So that protease that was supposed to break down the new viral proteins, so it started out maybe longer, and then it can block the proteases that break those to make the final product. Okay. So HIV pharmacology, no cure yet, but many drugs are being developed. People live symptom-free longer, leads to concerns about people being less cautious. Rates of transmission from mother to newborn are reduced, 70% decline in the death rate. Incidence of infections are still very high in African nations, but there's something called HIV-2 that's also common there that is less deadly than HIV-1, which is most of what we see in America. So there's a latent phase, the virus lies dormant. People often unaware that they have HIV, which can increase the spread of the virus. They can have it for years without knowing it and spread it to a lot of different people. So once diagnosis is confirmed, a decision is made about starting or delaying treatment. So the phases of HIV therapy, once HAART is initiated, it must be continued for the rest of the life of the individual in general. I mean, there are some exceptions where certain other treatments like cancer or something like that, you may have to go off of therapy, but otherwise you stay on the therapy or resistance could occur. You don't want to go off it and back on it again. So the therapeutic goal is to reduce that HIV RNA load in the blood to undetectable levels or less than 50 copies. Keep the T cell levels up, the T cell count up. So, and you want to increase the lifespan, give a higher quality of life, decrease risk of transmission from one person to another, but also from mother to a child, which has been pretty successful. So treatment failures, common. They're common with antiretroviral therapy. Patient non-tolerance of adverse effects, because there can be a lot of drugs, a lot of adverse effects. Patient non-adherence to complex regimen. A lot of times you have to take 2 or 3 pills 2 or 3 times a day. Even though there are some combinations, there's still a lot of medications that the patient has to take. Emergence of resistant strains can occur, genetic variability, so they can change. It's very expensive, so that's another kind of thing that's going to cause people to maybe not be able to continue treatment. So therapy is always changing, so it's important to stay current with the latest treatment. So let's kind of go through these. For the third time we're kind of going through this process. So we'll start with the fusion or entry inhibitors. Remember, that's the virus trying to get into the cells. And remember, so this Infuvritide, it's sub-Q injection, that's how it's administered, but it blocks the GP41. So it blocks there's a GP41 protein on the surface of the virus, blocks that, which is going to prevent fusion. Okay, so it prevents fusion with the CD4 cells. So the therapeutic uses are going to kind of be, similar, but treatment of HIV that is unresponsive to other retrovirals, localized reaction, these are adverse effects, localized reaction at the injection site, bacterial pneumonia could occur, fever, hills, I think that's supposed to be chills, rash, and hypotension can occur. Okay, so that was the fusion or entry inhibitors. Now, CCR5 antagonists are also entry inhibitors. The ATI book categorizes them, though, as specifically CCR5 antagonists. So if we draw our bacteria, or our cell again, and we say, okay, this is what the virus is trying to bind to. So here's the virus up here trying to bind to it, but it needs to have this CCR5. It needs to have that little co-receptor on there. So what drugs can do is they can come down and they can block that. They can block the CCR5, and if they block the CCR5, that means that virus can't bind. It can't enter. It may be able to bind, but it's not going to be able to enter without that CCR5. Okay, so that's it. Maraviroc. Maraviroc is the drug. Blocks CCR5 receptors, preventing HIV from entering the T cell. So again, treats HIV in conjunction with other antiretrovirals. Adverse effects, cough, upper respiratory tract infections can occur because, CNS effects, dizziness, paresthesias, orthostatic hypotension, hepatotoxicity. So this can be hepatotoxic, pseudomembranous colitis. I'm not sure why that would occur, but it can occur. So that's associated with Maraviroc, which is kind of fun to say. Zedoviadine. That's a nucleoside retroviral. Let's see. Sorry, I was stuck on retroviral. Reverse transcriptase inhibitor. Yeah, that's better. So nucleoside reverse transcriptase inhibitor, an NNRTI, is Zedoviadine. So this is the one that mimics the nucleotide thymidine. So remember, the goal here is we have RNA, we're trying to turn it into DNA, which means we need to bring in a whole bunch of new material, new stuff. And so what this does is that it mimics thymidine, which I was trying to say earlier. having a rough time. So it mimics that thymidine, and then it puts the wrong one in there. Okay, so as it's trying to put it together, now it's got a bunch of thymidines that are wrong, and then this thing will fall apart. That's what they do. Okay, so first line, antiretroviral to treat HIV infection. Adverse effects: suppresses bone marrow, Zedoviadine does, results in anemia, agranulocytosis, neutropenia, and thrombocytopenia. So you would treat with colony-stimulating factors. Can cause, remember, colony-stimulating factors, we talked about those for the online portion of the class, and those just cause more cell division. So lactic acidosis can also be caused nausea, vomiting, diarrhea, and then an enlarged liver, hepatomegaly, fatty liver can also occur, probably because of competition for metabolism in the liver. So the non-nucleoside reverse transcriptase inhibitors, NNRTI, so these are, I probably should have put that on there, non-nucleoside, okay, reverse transcriptase inhibitors. So these don't mimic it. They actually block the enzyme. So remember again, reverse transcription is when we're taking an RNA and we're trying to turn it into DNA. Okay? Well, there's an enzyme that also does that. Okay? So we block the enzyme, and then this process can't take place. So you don't have any reverse transcription. So treats HIV infection in conjunction with other antiretroviral medications to prevent resistance. Treats primary HIV-1, most common pathogenic form. That's HIV-1 is. Adverse effects: rash, flu-like symptoms, and these all treat HIV-1. So adverse effects: rash, flu-like symptoms, headache, fatigue, CNS effects, dizziness, drowsiness, insomnia, nightmares, mostly with efavirenz, which is another of the prototype drugs, Zedoviadine and efavirenz. Those are the prototypes. Okay, and then, not the last, but we're getting there, protease inhibitors. Your book doesn't go in order, and I went in the order of the book, because really after we've made the DNA, we're supposed to integrate it, but we're going to skip that step and come back to it, and now we have the viral DNA or the viral protein that's been made, and it needs to be cleaved. Okay, so it needs to be cleaved to make healthy, good, functional viral proteins. So protease inhibitors just stop it from being cleaved. So it never can make the good, happy viruses, which is bad. So it can't make those. So inhibit the enzymes needed to produce proteins involved in the construction of the virus. So therapeutic uses: treatment of HIV, combined with reverse transcriptase inhibitors and other protease inhibitors to increase effectiveness. Adverse effects: bone loss, osteoporosis, so you would include calcium and vitamin D in the diet because this is a risk. Diabetes mellitus or mellitus, hyperglycemia, hypersensitivity, so that would be shown as a rash, nausea, vomiting, elevated serum lipids, altered fat distribution, and rhabdomyolysis. Okay, all of these things can occur with the protease inhibitors that are supposed to be blocking protease inhibitors involved in the virus, the HIV virus. Ritonavir is the protease inhibitor. Integrase inhibitors, INSTIs. The raltegravir is the prototype drug for that, and so now we're talking about, so we kind of go back a step, sorry, but we've made the viral. Okay, so remember it started out as RNA, the viral RNA, and then it reverse transcribed to DNA, and now it has to integrate into the host DNA. So here's the host DNA over here, okay, and we want this to become part of it. So we want to add on to it. That's called integration. And what integrase inhibitors does, it's done with an enzyme called integrase. So we'll just say enzyme here, it's called integrase. It blocks that. And so this can't happen, so this can never integrate into the DNA. So raltegravir, Primary therapeutic use, first-line antiretroviral to treat HIV infection when combined with other HIV meds as part of that multi-drug therapy. Adverse effects, headache, difficulty sleeping, skin rash, liver injury, renal failure, hematuria, and suicidal ideation, which I think is interesting. But these are all things that were measured and reported, and so that's where the adverse effects come from, which is always the case, but true for this too. And that's our last drug for this chapter.